Welcome to the Encephalitis Podcast. My name is Prav, and I'm from Encephalitis International. Today, we will be talking about a study that took 20 years and extraordinary persistence, the DexEnceph study. To guide us through it, I'm grateful to be speaking to the study's chief investigator, Professor Tom Solomon. Professor Tom Solomon, CBE, FRCP, FMedSci, is a leading neurologist and infectious disease expert based in Liverpool. The president of Encephalitis International, Professor Solomon holds the chair of neurological science at the University of Liverpool, is director of the Pandemic Institute, and heads the Brain Infections Group, securing over £55 million in research funding to combat neurological disease globally. Professor Solomon is also academic vice president of the Royal College of Physicians and is a former vice president of the Academy of Medical Sciences. A passionate public communicator, he has won 2 Guinness World Records in this area and authored the book Roald Dahl's Marvelous Medicine after he provided care for the children's author. In 2021, he received a CBE for research on neurological and emerging infections. Professor Solomon, welcome to the Encephalitis Podcast. How are you doing?
I'm good, thank you very much. Now, I didn't hear any jingly jangly music. Does the Encephalitis International Podcast have music, intro music or not?
No, I think we need to work on that.
No,
It needs to
okay.
be more jingly and jangly.
We have to start that. I during the pandemic I ran a podcast called Scouse Science, where we were explaining what the hell was going on to people with a bit of a Scouse flavour, because a lot of the research was happening in Liverpool, and we had so what we did every time was we had a scientist, and we also had a famous face, we call them, so people off the BBC or television or radio or whoever. And but we started with this jingly jangly music at the start of every podcast to get the feeling going. I'll send you it, and maybe you'll have to add it post hoc to this podcast. Maybe play it at the end and see what people think of it.
Yeah, please do. I'd love to check that out. And I love the title, Scouse Science. That's amazing.
Yeah, thank you.
Just to start off, could you please explain the aim of the DexEnceph study?
Yeah, the DexEnceph study was to look at whether dexamethasone improves outcomes in herpes simplex virus encephalitis. So, as you know, and as many of your listeners will know on the podcast, I guess, herpes simplex virus is the virus which causes cold sores. And sometimes instead of causing a cold sore, it goes up into the brain and causes a nasty inflammation and swelling in the brain. And we have an antivirus drug that we use to try and control this called acyclovir. But because there's swelling and inflammation, if you scratch your hand, it goes red and angry. That's what we mean by inflammation. That's what's happening in the brain. And because of that swelling, there was always the question of whether dexamethasone, which is a corticosteroid drug, you've probably heard of steroids as well, whether that would help this disease because it reduces swelling. So on the one hand, people thought it might help, but on the other hand, the steroids are very strong immunosuppressants. They suppress the immune system. They stop the body's immune defenses. So there was always the worry that the drug might actually make things worse, because if the immune system is suppressed, then the virus maybe could replicate without any control. So that was the research question, whether dexamethasone improves the outcome. And it took us a long time to get there.
Yeah, you've described it as a long, winding journey that involved dozens of hospitals and hundreds of people, but it all began with a small meeting in London in 2006.
That's right. It was a meeting of the Encephalitis Support Group, which was the original name for this wonderful organization. It changed from the Encephalitis Support Group. And as you may know, originally, it literally was just a group supporting patients and their families. I joined the scientific advisory panel, or it was just called the advisory panel back then, quite soon after it was founded. And then it became the Encephalitis Society many years later, because it was doing more than just supporting families and patients. It was also raising awareness and advocacy, and also supporting research. And then most recently, it became Encephalitis International a couple of years ago. But when it was still the Encephalitis Support Group and was thinking about getting involved in supporting research, we used to meet once a year. And it was at one of these meetings in London that we were discussing this question again. And we said, well, maybe we should get on and do a study to try and work out whether steroids are helpful or not. So that was back then in 2006. It took a little while, as always, to get things going. In fact, it took a couple of years to write the research proposal and get funding, and we got that funding approved in January 2009. But by then, there was a study in Europe looking at exactly the same question. So we said, well, why don't we just follow their protocol and add a UK arm to their study, and then we can put all the results together. So that was the original plan. But it became clear by the time we got the funding that the European study was failing to recruit enough patients. It was going to have to stop. So rather than us take money to get a study started that was never going to answer the question, we actually sent the money back to the funder, National Institute for Health and Care Research, and said, look, this is going to fail. Rather than spend your money on something that's going to fail, we'd rather not start. So that was a very painful thing to do. But we then subsequently, a couple of years later, wrote a new research proposal saying, rather than doing this with Europe, let's just do this across the UK, involving lots of hospitals across the UK. And we got funding to do that in 2014. So it was actually 9 years between thinking of the study and actually getting the first patient into the study.
Amazing. Yeah, I was going to ask you about that decision to return the funding, and I was wondering how did you come to have the courage to do that?
Well, I'm not sure it was courage. I just couldn't face. I mean, these things are so difficult anyway. But to be embarking on a study when you already know it looks like it's going to fail, um, they're enormous efforts. And also you're asking patients and families to get involved. And I just didn't, in all conscience, think we could do that when it looked like, we would be contacting them a year or so later saying, actually, we're stopping the study because it's not recruiting enough patients. Um, so, I mean, it wasn't a very popular decision with the university because they kind of like you to bring research funding in and spend it. Um, but it just felt like the right thing to do at the time. And I think it did get us some credit with the funder, so that when we went back with our own proposal, they at least knew that we'd worked out how to do a study that would not fail, that would succeed. And we learned a lot from, so the European study was led by a woman called Uta Meiding-Lamade in Frankfurt. And she was very helpful. We looked at why her study had failed to recruit, and she helped us design our study. And basically, they'd been too fussy. You always get this kind of trade-off. The sort of pure academics want everything to be absolutely perfect and so and so. And for example, they'd been a bit fussy about how quickly you get patients in the study. Ideally, patient comes to hospital, you get them in the study the same day. But the reality is it takes longer than that. And so with ours, we were much more flexible about saying, we didn't want to miss patients. We thought once you've got a study up and running, you don't want a patient comes to the hospital, could have got into the study. But because you said, in fact, she said they have to be recruited within 5 days of their symptoms. Well, they might not have come into hospital until 4 days of symptoms. So that means you've got 1 day to try and get them in the study. And we thought that would be a real shame to miss people. So we configured it to try and make it easy to put patients into the study and keep them in.
So I just want to also get into the nitty-gritty of how the study was carried out. I think in your piece you also talked about a man in the man in the mini. Could you talk about that as well?
Yeah. So there were two things. Like I said, once academics get started, they want to do, let's do this and let's add this and let's do the brain scans and let's get blood samples and let's get spinal fluid and we could study the inflammation response and we could look at how much virus there is. So what tends to happen is once you get started, people always want to do more. But then, and that again was, I think, partly why the German one struggled. And so our feeling was, okay, we can add those things on, but we've got to be dead clear to the patients and the doctors doing the study. There's really only two important things. One is you've got to get the patients in. So if there's anyone eligible, try not to miss them, try to get them in. And then the other thing, what we discovered early on was that because of all these extra things that were being asked, can you do a scan? Can you do this? We want, you do want all that information, but that's not the priority. The priority is the primary outcome, the main outcome of the study. And in our case, we chose as the main thing we were going to measure patient's verbal memory score. And that's because one of the biggest things, as you know, with patients with encephalitis, especially herpes encephalitis, their verbal memory goes, they can't remember the names of things or the names of people. And they have lots of other problems as well. But that's the sort of single, if you had to choose one thing to measure, that would be the single most important thing to measure. So that was our primary outcome. And its score ranges from, a bad verbal memory to good, if you like. If people were too sick with the disease, and we measured this verbal memory at 6 months, if they were too sick, you couldn't even do the test, we gave them the lowest possible score. And if sadly they died by 6 months, then we gave them the lowest possible score. So the verbal memory was the key outcome. And so we said to people, the doctors, nurses in the hospitals, and the patients, look, we're measuring lots of things, but the most important thing is we get the verbal memory score at 6 months. We focused on that. We had a neuropsychology student called Corey Hooper, who his job was basically to track all these patients down and make sure we didn't miss a single patient. And so he would, ideally you would do this in hospital, people had their assessments in a clinic, but that, if that wasn't going to work, he would get in his Mini and travel around the country, go and visit them at home, whatever was needed not to miss a patient. Once they're in the study, we mustn't miss that outcome score. He didn't really have a Mini, but that's how we thought of him. He did most of it on the trains. And then also, especially during the pandemic. So this happened, the pandemic occurred towards the end of the study, and all national studies stopped because all research was focusing on COVID-19. But so we stopped recruiting patients. But again, if somebody was already in the study, we didn't want to fail to get their outcome because they, because of the pandemic. Because if you don't get that outcome, everything you've done with them has been wasted. So he would go and visit them at home. I think he would even, when he couldn't, be in the same room as them, I think he'd sit in the garden and talk to them through the kitchen window to assess them to get their verbal memory score. So, and he used devices. I think he used iPads, and people would be on their iPad and he'd be on his. So, he did a brilliant job and made sure that we got enough patients so that by 2022, when we recruited the last patient, and then followed them up, we had more than 90 patients in the study, which was enough. We knew that would be enough to tell us whether the drug had worked or not.
That's really inspiring. Even a pandemic couldn't come in the way of such important research. And you have talked about how patients and families were the real heroes who agreed to participate at an incredibly difficult time in their lives. So I was wondering, what does their involvement mean for you personally?
Well, it's all about the patients, isn't it? I think as a doctor from day one, as a medical student, it's a very privileged thing that people let you into their lives to try and help them, try and look after them. And I think you're humbled by that on day one as a medical student. And I think one always is humbled by it. And especially the case when you're asking, you're not just trying to care for them, but you're saying to them, would you mind if we put you in a study? There's this really important question that we're trying to answer. And you won't necessarily benefit from being in the study directly. If the drug works and you ended up in the arm that did not get the drug. And I didn't really explain that, but it was one of these studies where every patient is randomized to get the drug, the steroid, in addition to normal care, or to not get the steroid. And also, really importantly, to avoid bias, Corey, who was doing the final assessment, didn't know whether somebody got the drug or not. Clearly, that's really important. Actually, it's interesting. I think since the pandemic, I think the public now has a better understanding of what research is and, these kind of concepts, because so many people were in, for example, the COVID vaccine studies or the COVID treatment trials. But anyway, so, you're saying to patients and families, look, we want to put you in this study. You won't necessarily benefit from it directly, although actually people do indirectly benefit. So there are good data showing that patients who are in hospitals that are research active tend to have better outcomes, even if they're not being studied in a study. They just the environment tends to be a bit better. But they, agreed to be in the study, and of course, it may not help them, but it would help future people with this disease. And And also when you talk to people, you say, well, look, all the things, for example, we know to give your loved one acyclovir, the antivirus drug. We only know that works because in the 1980s, people did studies to show it worked. So I think most people get it, and most people are happy to be in the study when you talk to them and explain it to them like that. And of course, we did get an outcome. We did get a result at the end of. So we recruited the last patient in 2022. We started the analysis and write-up in 2024, and we published the paper earlier this year, 2026. And what we found, it was very interesting. So steroid dexamethasone on its own did not improve the outcome overall of people with herpes simplex virus encephalitis. So that was a disappointment because we'd hoped it would improve the outcome. But there were two other important things. The first thing was that it certainly did not make patients worse. And we knew it didn't make them worse. And also we measured virus in their spinal fluid and showed that even if they got the steroids and their immune system was suppressed, you didn't get uncontrolled virus replication. So, and that's important because you'll know about other types of encephalitis like autoimmune encephalitis. And that we know steroids help with that. And we want to give the steroids as soon as possible. So up until our study, when patients would come with encephalitis, you'd think, well, is it autoimmune or is it infectious? We're going to have to wait and get the results of the herpes test. And if it's negative, we'll give them steroids because we think it's autoimmune. But now we know that actually, because steroids are not harmful, as soon as we see a patient with encephalitis, we can probably start them on steroids straight away. If it's HSV, it won't harm. If it's autoimmune, it's great because we've got them started on the steroid immediately. And typically, it would take a day or two for people to determine. So that's the positive result that we were aiming to look at. But then, even more interestingly, because when we were presenting the data at meetings, including the Encephalitis International Conference in London at the Royal College of Physicians, we presented the data. And as I'd mentioned, we didn't, because of the German study, which failed, the European one, we didn't say you have to get the patients in the study within 5 days or even 10 days. We just said, get the patient in the study as soon as you can. Now, that was in some respects a mistake because some patients, the latest one, didn't get in the study until 21 days. They'd been in hospital 21 days. Now, that was not ideal. And in retrospect, we probably should have had a cutoff. But what it did mean was that some of our patients got the drug very late, probably too late for it really to have an impact. And when you looked at the data, people said, well, why don't you just look at within the steroid group, is there a difference if you got steroids early or late? And we looked at that and we found that steroids improved outcomes in patients who had steroids earlier than those who got them late. And it was very clear the verbal memory score was much better if you got steroids earlier than if you got them late. So again, we think that's going to be an encouragement for people to now treat herpes simplex virus encephalitis or suspected HSV encephalitis with corticosteroids. So in the end, although it didn't give us the headline result that we would have liked, we sort of got there in the end. We know it's safe, and we know that it may even be beneficial if you give it early. And the guidelines, the European encephalitis guidelines, are just being redone, and I think that's probably what they will say.
That's so important. And yeah, you mentioned a day or two, but that's at such a critical time. That's so important. And one of the things that stood out to me from your response just now is how you retrospectively look at the trial and you can still see things that you could change and improve. And that leads me on to my next question, which is, what advice do you have for medical and healthcare professionals who want to conduct a long-term clinical trial?
There's a bit of me that wants to say, don't do it. It will. I mean, and this has taken now for me, I think it's 9 years, 18, 19, 20. It's about 21 years of my life. My youngest daughter hadn't even been born by the time when we started this study, and she's now at uni. So I actually, what I would say is don't do it, because it's been a tremendous thing to do, and it's answered an important question, and it's been if I'm honest, a lot of fun along the way. We've made some really good friends, built some strong relationships across the UK and with European partners. But what I would say, and I do say this to researchers in the team, don't jump in. Take your time with any research project. The temptation is to jump in. You want to write the project quickly. You want to try and get funding quickly. Well, for a start, if you write your research proposals quickly, they tend not to be that good, and you may not get funding. But the one thing that's worse than not getting funding is actually getting funding for something that's not very good and not really going to answer the question. And I've seen that. So I always think take your time in thinking about what you want to do. And a bit like we did, look at similar stuff that might have gone wrong, talk to those people, get everything, get all the information you can together before you jump in. And then when you do jump in, if you don't get funding straight away, then be ready to jump in again, go back, don't give up. I mean, more than anything else, you have to not give up with this kind of initiative if you really want to answer the question long term.
Absolutely. Thank you for that, Professor Solomon. And we have come to the end of the podcast. And just before we finish, is there anything that we have not discussed that you'd like to mention?
Well, we haven't. I think one thing that's really important to emphasize, especially given the, it's the Encephalitis International podcast, but I mean, I've said the same to friends at the Lancet who published the paper, is the importance of charities like Encephalitis International in this kind of initiative. It's true to say, I sometimes tell the story that my research career started with working on encephalitis in a global sense. Japanese encephalitis was the biggest disease I studied. And I was back in the UK. This is in 1998. The encephalitis support group had been running for a short while. And I went along, they asked me to go along to a meeting to talk to people. It was a meeting of patients and families. So I talked a bit about my work on encephalitis in Asia, Japanese encephalitis. And as you know, people who've got brain damage sometimes are a bit disinhibited. They shout things out that maybe in polite company you wouldn't. And there was this guy on the front row shouted out in the middle of my talk, "Yeah, but what's this going to do to help people like me?" I kind of thought, oh, yeah, you're right. Actually, we've been doing all this work in Asia, and we're not doing any work for patients with encephalitis in the UK. So our whole UK research program started really at that moment, from the contact with the charity. And since then, the UK research program has grown and grown and grown. So the DexEnceph study was the most recent of a series of studies looking at encephalitis in the UK with a lot of funding. And the Encephalitis International charity has been a partner through all of that, helping us decide on the research question, helping us make sure that we get the not just the question right, but that we engage with patients to understand what's going to matter to them, hence the verbal memory score as the outcome score. And then also really great partners in terms of raising funding and making the study happen. And, among the many people who've helped, Ava Easton, of course, has been a fabulous partner in crime for me over all these years. Others at the charity, Philly Chapman and many others, the patient and public reps who sat on our advisory board for the study, Rachel, is it Tarleton? I think it is. I hope she won't mind me giving her a shout out. And then colleagues, doctors, nurses, and academic staff who've helped with the study. Nick Davis has been brilliant, and Ben Michael, so many people really. But these are enormous team efforts, and it's really, I've just been the figurehead and the person who got it going, but you really need a great team to make something like this happen. And I've really been lucky to have that kind of team support all the way.
Amazing. Thank you. Thanks so much, Professor Solomon, for sharing your time and expertise with us. It's been a pleasure having you.
Thank you for having me. Now, cue the music. I'll send it you. We'll have to add it
on. That was Professor Tom Solomon, CBE, FRCP, FMedSci, Chief Investigator of the DexEnceph study. And finally, I'd like to thank you, the audience, for listening and watching. If you have been affected by any of the issues raised wherever you live in the world, please contact our support services. Encephalitis International is here to help in whatever way we can to achieve our aim of ending death and disability from encephalitis. For all our information, as well as details on how to donate, please visit encephalitis.info/donate. Thank you again, and see you next time on the Encephalitis Podcast.
Aye. And cut.